بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we will start inshallah a new series of lectures about the spinal imaging, and we will handle in this series imaging of the normal anatomy, then degenerative diseases of the spine, then evaluation of post-operative spine, then spinal trauma and spinal infection and the spinal tumors, and possibly we'll discuss also the spinal dystrophism, or we may postpone this issue to the pediatric imaging. Then now we'll start the imaging of the spine by the normal anatomy. And you know, we have many ways for evaluation of the spine. One of the most important of them is the plain X-ray or the spinal radiographs. In the spine, we may have the anteroposterior view, the lateral view, oblique views, dynamic views, standing views, and the bending views. Not all these views are performed for every segment of the spine, but there are basic radiographs. Then we may add some of other views according to the clinical condition of the patient and the provisional diagnosis. In the lumbar spine, we have the standard views, including the anteroposterior view and the lateral view. And many times the lumbosacral junction is not that clear in the lateral view, so we should have a spot film for the region of the lumbosacral junction, as you can see here. In the lumbar spine, we may have the oblique views, and the oblique views are usually directed for evaluation of the facet joints. These are the facet joints, which are the articulations between the inferior articular facet of the vertebra above and the superior articular facet of the vertebra below. Also, we can evaluate the sacroiliac joints in the oblique view more better than the anteroposterior view. And also, this oblique view is good for evaluation of the pars interarticularis, which is the junction between the pedicle and the remaining part of the neural elements. As you know, this pars interarticularis corresponds to the neck of the Scotch dog. In the oblique view, you can see this is the head of the dog, which is performed by the mouse corresponding to the transverse process, the eye corresponding to the pedicle, the ear corresponding to the superior articular facet of the vertebra below, the neck, which is the pars interarticularis, and this is the region of the pars interarticularis. And you know, when this part is broken, there is a possibility that the vertebra will slip over the underlying vertebra, particularly if both pars interarticularis are broken. The standard views in the cervical spine include the anteroposterior view and the lateral view, and many times we can have this projection, which is known as open mouth view, where you can evaluate the odontoid process as well as the atlantoaxial articulation. In the oblique views of the cervical spine are directed for evaluation of the neural foramina. These are the neural foramina, which are evaluated for the possibility of osteophytes, for example, protruding into the foramen, or any abnormal density or calcium within the foramen. Then also this oblique view is good for evaluation of facet dislocation, as in cases of trauma, and is better for assessment of the possibility of a small cervical rib in the oblique view. If the rib is small, you can see it good or better in the oblique view. Dynamic views of the cervical spine are usually obtained to assess the spinal instability, and also they are good in the evaluation of the lumbar spine. Then we have the lateral view in the neutral position. Then we have a view during extension and another view during flexion, and we assess the vertebral alignment during these positions for any possible spinal instability. In the dorsal spine, we only have the anteroposterior view and the lateral view. We don't have other additional views in this particular segment of the spine. Then what to evaluate in the spine by the plain X-ray? We have 3 items for evaluation. Number 1, the alignment. The vertebral alignment, whether lordosis in the cervical and lumbar, kyphosis in the dorsal, and if the curve is straightened, we may say that there is a straightening of the lumbar curve, for example, or cervical curve. Then we look for the bony texture, if the bone density of the vertebrae are normal, or there is osteoporosis or increased bone density, like sclerosis, for example. Then you look for the disc spaces in the lumbar spine. The disc spaces are increases in width whenever you are going down. And that's to say that L4-5 should be wider than L3-4, which should be wider than L2-3 disc, intervertebral disc. Then in every segment of the spine, we assess a 4th item. In the cervical spine, we look for cervical ribs. In the lumbar spine, we look for the sacroiliac joints. In the dorsal spine, we look in the paravertebral area for any abnormal soft tissue shadows. And in this particular part of the spine, we can assess the paravertebral abnormalities because of the presence of air in the lung, which helps to detect these abnormal soft tissue shadows. And how to report the X-rays of the spine? Number 1, you look for the alignment. If the curve is preserved, then you say good alignment or preserved lumbar lordosis. Then you look for the bone density, and if the density is good, then you say normal bony texture of the lumbar vertebrae and their appendages. Then you assess the width of the disc spaces. If they are good, and you say well-maintained disc spaces. Finally, you look for the sacroiliac joints, and if they are normal, you say sacroiliac joints are free. And if there is a scoliotic deformity, you mention that there is a scoliotic deformity which is convex to the right side. And we mentioned the scoliosis by the direction of the convexity, not the concavity. And in this cervical spine, you say that there is a straightening of the cervical lordosis. The curve is obliterated, and the bony density is good. There is normal bony architecture of the cervical vertebral bodies and their appendages. In the cervical spine, the disc spaces are equal. Then C2-3 should be equal to C3-4, and so on. And you see here the disc spaces are well maintained. And finally, you look for the presence of a cervical rib. How to assess for the cervical rib? And you know that the transverse process of the cervical vertebra is horizontal or somewhat looking inferiorly, while the transverse process of the dorsal vertebra is looking upward. Normally, you can see is a rib attached to the transverse process of the dorsal vertebra, which is looking upward, but you cannot see a rib connected to the transverse process, which is horizontal or looking inferiorly, because this belongs to the cervical spine. And in this case, you can see that there is a small rib here attached to the transverse process of C7, and there is also a small bony cervical rib here attached to the left one. This is also a good example of cervical ribs, and you can see the rib on the left side is somewhat longer than that on the right side. In the dorsal spine, if kyphosis is maintained, you say good alignment. You look for the bony texture, and if it is good, you say normal bony architecture of the dorsal vertebrae and their appendages. Then look for the disc spaces, which should be equal. Then you say well maintained disc spaces, and you look in the paravertebral area for any abnormal soft tissue shadows. If no, you say no abnormal paravertebral soft tissue shadows seen. At the time, this technique was frequently done in the battery of investigation of the spine, which is the myelography. By myelography, we mean that we inject some of the contrast media in the spinal canal inside the cecal sac. Usually, we sterilize the back of the patient and we palpate the spinous process of the vertebrae, and we introduce a lumbar puncture needle between the transverse processes of the spine, aiming at the cecal sac or inside the spinal canal. Usually, the level we select is between L3 and L4. We may also select L2, 3 level, and don't go above this because of the presence of the conus medullaris. And this is the L4-5, which is not recommended because this disc space is usually pathologic and there is relative narrowing of the interspinous process. So you should go a little bit up here or there for introduction of the needle. Then after introduction of the contrast material inside the spinal canal, if you are aiming at the lumbar spine, then go ahead to have the radiographs in the supine and erect position. But if you are aiming at any other segment of the spine, you should tilt the table so that the contrast media will pass from the lumbar spine into the dorsal or in the cervical spine. Then you reposition the table and have your films. In the lumbar spine, we have the frontal view, lateral view, and both obliques, left and right, during in the supine position as well as in the erect position. And here we are looking for only the presence of disc lesions. If there is an indentation of the contrast column opposite the disc space, you may assume that there is some disc bulging inside the spinal canal. And we, by certain criteria, we were able at that time to discriminate between disc bulge and disc herniation, but the discrimination was not that accurate at that time. In the cervical spine, we may have the frontal view and this lateral view, which is known as the cross table view or lateral view with horizontal beam, aiming at the delineation of the contrast column, which in this position will be dependent inside the spinal canal, lying on the posterior aspect of the vertebrae as well as disc spaces. So any small disc lesion which is going inside the spinal canal will indent this contrast column. And many times in the era of myelography, we used to diagnose spinal cord lesions by this appearance. Here you see the normal configuration of the spinal cord as a filling defect within the contrast column. And here you can see that the cord is expanded, the negative shadow of the cord is expanded, and the contrast media along the cord has been attenuated. This means that there is some specifying lesion inside the substance of the cord. after the development of CT, and we have used the benefits or combined the benefits of myelography and CT by doing this technique which is known as CT myelography. After injecting the patient with contrast and having the normal or the routine radiographs for the spine, then we transfer the patient to the CT machine, and we have axial sections where you can see the contrast media inside the cecal sac and the nerve roots as dots filling defects within the cecal sac. And the recent machines can reconstruct the images in the sagittal and the coronal planes so that you can have these beautiful images. Also in the cervical spine, in the axial images, you see the negative shadow of the spinal cord surrounded by the contrast medium, and in the sagittal reformatted image you see the cord as a filling defect within the contrast column. Then we came to the CT scan, and CT is considered one of the valuable modalities for evaluation of the spine at a time before the era of MRI, and now its role has been regressed a little bit as a primary imaging for the spine. And in order to have the CT scan of the spine, we put the patient in the supine position on the CT machine, and we have the scanogram in the lateral view, and we start to prepare to decide if the patient is going to be injected with contrast medium or not. We usually inject the patients with contrast media whenever we are suspecting an inflammatory disease or a tumor in the spine. And also in cases of post-operative lumbar spine, we may inject contrast media to differentiate between recurrent disc and post-operative fibrosis. While in other conditions like assessment of the spine for disc lesions, assessment of the spine for trauma or congenital anomalies, we do not usually need intravenous injection of contrast media. And we have two ways for evaluation of the spine by CT. The first one is the scanning for disc lesions. In the lumbar spine, we have the scanogram in the lateral view. Then we identify the disc spaces, and we put two lines parallel to the disc space itself, starting from the lower part of the vertebra above to the upper part of the vertebra below. And the scan interval here is 4 millimeter. In the cervical spine, it will be 2 millimeter because of the small size of the disc in the cervical spine. Then the operator should align the scanning parallel to the disc itself so that we are able to have a section which is passing accurately within the disc substance. Then we use the bone and soft tissue window settings, and if this is a post-operative spine, we may inject contrast media. The second way for injection of the spine is scanning for other lesions other than the disc, such as in cases of trauma, in cases of infection, in cases of neoplasms, and in some miscellaneous conditions. These scans are obtained by performing a scanogram in the lateral view, and then we identify the scanning area from L1 to S1, just one block to be scanned, and we usually use the scan interval at 3 millimeter so that we are able to reconstruct the images in the sagittal and in the coronal planes after that. These reconstructed images are very good for evaluation of the spine considering these conditions. And here you see this is a fracture at the level of L1 vertebral body with depression of the superior in the plate, and the fracture is extending into the pedicle and the neural elements. I will discuss this in details in the lecture of spinal trauma. Also, you may able to have the 3D images for the scan the segment of the spine, whether in color or without color. But in my opinion, I consider the 3D images of little value in the diagnosis of any part in the human body except for the maxillofacial area. And I will show to you the benefits of the 3D images in the maxillofacial trauma when I am talking in the lectures of the head and neck imaging. But I believe that the 3D images anywhere in the body are of little value in the diagnosis, whether they are projected in color or without color. And these are the spinal images or the scans which should be obtained in the soft tissue window setting as well as in the bone window setting. Then whenever we are evaluating the spine, we usually ask ourselves what we are going to evaluate, and if this part is a bony part or a soft tissue part. Then if we are evaluating a soft tissue structure, we should look in the soft tissue window. While if we are evaluating a bony structure, we should look in the bone window images so that we can do accurate evaluation. Then what are the items for evaluation in the spine by CT? They are three. Number one, we should evaluate the spinal canal for canal stenosis. We should evaluate the discs for disc pathology, and we should evaluate the joints, the facet joints in the lumbar spine, neurocentral joints in the sacroiliac spine, in the cervical spine, and the sacroiliac joints. Also, we look for the paravertebral soft tissue structures for any abnormality. Then, in starting evaluation of the spinal canal, you ask yourself about the canal. Is it bone or soft tissue? Then you know that the spinal canal is bone, but inside the spinal canal is soft tissue. But here we are going to evaluate the spinal canal itself, the bony spinal canal. Then we should go in the bone window images, and you select the image where the spinal canal is closed. I mean the level of the pedicle of the vertebra. And at each level, at L1, L2, L3, L4, and L5, you should measure the sagittal diameter or the anteroposterior diameter of the spinal canal. And normally, the anteroposterior diameter of the spinal canal is 13 millimeter or 1.3 centimeter. Then if you measure the diameter of the lumbar spinal canal, and you can see the distance here is 1.2, you know that this canal is relatively narrowed, while here is 1.1 is also relatively narrowed, and here is 1.0 is also narrowed, and 1.1 is also narrowed, 1.4 is normal. Then you know that the diameter of the spinal canal may be normal at some levels and may be narrowed at other levels, and you should mention this in the report. Then the second issue is to evaluate the disc for any abnormality. Then you know that for this disc lesion, for example, for this disc level, we include part of the vertebra above and part of the vertebra below, as well as we scan the disc itself. Then you ask yourself, the disc is soft or bone? You know that the disc is a soft tissue structure. Then you will evaluate the disc in the soft tissue window images. And also you should go to the section which has passed through the disc substance itself. Like in this example, you can see here that there are three sections, and you want to select one for evaluation of the disc, and you should know where is the disc. The disc is the soft tissue structure which is similar to the soft tissue muscles along the sides of the vertebra. Then, if you look for this section, for example, this area do not appear like the muscles, then you are cutting in the bone. And here also you are cutting in the disc as well as in the bone. But this level you are cutting actually in the disc, and this is the value of aligning the section parallel to the disc substance to the direction of the disc itself. Then if you go to the section that has passed through the disc substance, How can you evaluate the disc? Just look for the posterior edge of the disc, which is of course very important compared to the anterior border of the disc. The anterior border of the disc is not that important, but the posterior one is very important because it belongs directly to the cecal sac and the nerve roots. The normal posterior border of the lumbar disc is concave. Then if you see the border of the lumbar disc concave, then you know that you are dealing with a normal disc. And if you look here, this disc has a subtle concavity in the posterior border and is considered within normal as well. This appearance is usually seen in adolescents, and this is usually seen in adults. But this disc with convex posterior margin is considered abnormal. This is disc bulge or herniation, as we will discuss after that. Then came to the L5S1 disc. You know that L5S1 disc is carrying the body weight until it is divided into two into two halves on the sacroiliac joints. Then this disc is suffering every time, and it's allowed for the L5S1 posterior border to be convex like this, and you consider L5S1 is normal at that time. Then how can you discriminate between the normal and abnormal disc at L5S1 level? It's an easy process. Just look to the L5S1 disc and you see that its posterior border is convex. Then go to the next section after that and look inside the spinal canal. If you see disc material, then you know that this disc is abnormal. But if you don't see any disc material, like in this case, this is the border of the sacrum, and this disc is normal. Then I give you an example. Look for this L5S1 disc and you can see that the posterior border is convex. Then you go to the next section and you see that there is disc material inside the spinal canal, and this disc is abnormal. And this is also an example for abnormal L5S1 disc. At the level of the disc, you see convex posterior margin, and the next section you can see disc material inside the spinal canal, and you consider it abnormal disc. Then anyone can say safely that L23 disc is absolutely normal, and also L34 disc is also normal because it has a concave inner posterior border. Then for evaluation of the facet joints, which are the articulations between the superior articular facet of the vertebra below and the inferior articular facet of the vertebra above, and this facet joint is bone, and you cannot evaluate in the soft tissue window unless you will do some mistakes, because the evaluation of the facet joint is directed mainly for the detection of osteoarthritis, and one of the main manifestations of osteoarthritis is narrowing of the joint space. Then if you look here, you may say falsely that the joint space is narrowed, which is not the case. But here, these are the normal appearance of the facet joints, and these are the facet joints showing advanced osteoarthritic changes because of the narrowing of the joint space, a particular bone sclerosis, osteophytic clipping of the articular surfaces, and interarticular air representing the vacuum phenomenon. In the cervical spine, we have another joint, which is the neurocentral joint, which is the joint between the vertebral bodies. And you see in the cervical spine that there are two elevations on either side of the superior surface of the vertebra, where the vertebra above is articulating with the vertebra below. Then if you have a section in this area like this one, and you will see that there is a small bone, then joint space, which is the neurocentral joint, then a large bone, which is the vertebral body, then another joint, which is the neurocentral joint, and a small bone. Then look here, this is the small bone, the neurocentral joint, the large bone of the vertebral body, the neurocentral joint, and the small bone after that. Then in the cervical spine, you have two joints, the facet joints, like in the lumbar spine, and the neurocentral joints between the vertebral bodies. And you evaluate both joints for the presence of osteoarthritis. And how can you evaluate the cervical discs? And then you know that the cervical discs are usually small. Then whenever you are cutting by CT scan at 2 millimeter scan interval, you are not able to cut in the disc substance pure without bone. And you should see bone along the margins of the disc. Then you go to the section where you can see disc material and look along the posterior edge of the bone. If you don't see disc material, this is a normal disc. If you see disc material like this and this disc is abnormal, and I will explain how you can separate these abnormalities. But starting by the anatomy, I would like from you to identify the normal from the abnormal. And this is an abnormal C5-6 disc because there is disc material beyond the posterior edge of the vertebra, and this is also abnormal C6-7 disc because of the presence of disc material beyond the posterior edge of the disc. Also, the facet joints in the cervical spine and the neurocentral joints are evaluated for osteoarthritis. And you know, this is the neural foramen where the nerve root is going through the neural canal. If there is osteoarthritis here and there may be osteophytes which are encroaching on this canal, like in this example. This nerve root canal is good and this nerve root canal is narrowed because of the osteoarthritis of this neurocentral joint. Then we came to the role of MRI in evaluation of the spine. And you know, we have different machines, the closed magnet and the open magnet, the extremity magnet, which is not good for the spine, of course, and the dynamic magnet, which is very good machine for evaluation of the spine, pre and post-operative. I have explained this before, and you remember that any patient with a surgery in the back for the spine, then he may suffer some pain post-operative, and if you examine the patient during or in the spine position, you may not be able to find the abnormality. But if you examine the patient in the upright position with axial load on the spine, then you can see evident spinal instability as in this example, and you can appreciate marked narrowing of the spinal canal while the patient is in the erect position. This machine, as I have said before, is no more just for the spine, but it can examine all parts of the body using the different surface coils. And in order to examine the spine, you should use the surface coil. The best surface coil should be close to the spine and does not move with respiration. So the surface coils for the spine are like this, where the patient lies on his back and the coil is very close to the spine and does not move with respiration. The protocol of examination of the spine by MRI should include sagittal T1, CSF is black, sagittal T2, CSF is bright, axial T1 and axial T2. The scan slice thickness is 4 mm for all segments of the spine, cervical, dorsal, and lumbar. There is no interslice gap, and we may inject gadolinium also in cases of inflammation, neoplasms, and post-operative lumbar spine. Then many can easily discriminate between the MRI images and the sagittal reformatted CT images. Of course, the end plate of the vertebra in the CT is dense or very bright, while the end plate of the vertebra in any pulse sequence of MRI should be black because of the absence of mobile protons. The vertebral end plate is black in the T1 and T2 in the stair in any other pulse sequence. Then also you can discriminate between the axial CT image and the axial MRI T1 weighted image. And the protocol of MR examination of any segment of the spine should include sagittal T1, sagittal T2, axial T1, and axial T2. Many times we use the facilities of MRI to have this MR myelography, and we don't use any contrast media. We do not inject any contrast media inside the spinal canal, and we have special pulse sequences to obtain these beautiful images without any invasive techniques. This is the difference between conventional myelography, where you can see the bones, while in the MR myelography you cannot see the bone, you see only the CSF. And this is sagittal T1 of the lumbar spine, CSF is black, sagittal T2, CSF is bright, and myelography in the oblique view, and you see a big perineural cyst in the sacrum, which is also appreciated here. Then we do not usually routinely use the coronal images in the protocol of spinal imaging, but sometimes we may need the help of coronal images in cases of scoliotic deformities, the presence of paravertebral soft tissue shadows, and the presence of intraspinal pathology like this meningioma in the subdural space. I will explain this in full details after that. Then what are the items to be evaluated in the spine by MRI? Of course, you need to know something about the spinal canal, if it is normal or narrowed. What about the discs, if there is any disc bulge or herniation? What about the prevertebral shadows? And there are some benefits of MRI which cannot be obtained by any other imaging modality. These are the ability for evaluation of the spinal cord and also the detection of bone marrow abnormalities. Starting by the spinal canal, we can measure the spinal canal like we measure it in the CT scan, and the diameter is the same. The normal diameter is 13 millimeter up to 19 millimeter. This is the normal sagittal diameter of the spinal canal. Below 13 millimeter is considered the stenosis. Above 19 millimeter is considered the capacious spinal canal. Then, if you look in the axial image, without measuring the diameter of the spinal canal, if you can see that the cecal sac is rounded and is surrounded by adequate epidural fat, then you can consider that this canal is normal. Also, in the sagittal view, if you see the coda equina nerve roots are surrounded by adequate CSF, you consider this canal is normal. Then you can easily say that this canal is very tight because the coda equina nerve roots are running in a very tight canal with little amount of CSF around, compared to this normal canal with adequate CSF around the coda equina nerve roots. Then in the capacious lumbar spinal canal is the canal with diameter measuring about 2 centimeters or above. And this is a capacious spinal canal, and many clinicians consider that capacious canal causes some sort of low back pain because of the ectasia of the cecal sac, which is not adequately supported by bone posteriorly. Then in the cervical spine, in order to assess the spinal canal, you look for the sagittal T2 midline image, where you can see the spinal cord, and there should be a CSF space anterior to the cord and another CSF space posterior to the cord. And if you see this, and you consider the canal is normal. But if there is no CSF space anterior to the cord and no CSF space posterior to the cord, then you consider the canal is tight or stenotic. I will also discuss the details of spinal canal stenosis in the lecture of degenerative diseases of the spine. But now we are going to evaluate the disc. In the lumbar or the cervical intervertebral disc is made of two components, the annulus fibrosus and the nucleus pulposus. The nucleus is cartilage containing water. It will appear black in the T1 and bright in the T2 weighted image. Then the normal disc will appear black in the T1 and bright in the T2, and the posterior edge of the disc should not exceed the posterior edge of the vertebra above and the vertebra below. Then if you look in the T2 weighted image and you can find that L5S1, for example, is black, that is to say it has lost its water content, meaning that it is degenerated disc, and the disc is also going inside the spinal canal, meaning that it is a disc bulge or herniation, as I will discuss after that. Also in the cervical spine, you can see the cervical discs containing a small amount of water. They appear bright in the T2 weighted image. They are parallel or in flush with the edges of the vertebra above and below. They do not exceed the margins of the vertebra and do not extend inside the spinal canal normally. Then the bone marrow is made of fat, is containing fat, and the fat will appear bright in the T1 and less bright in the T2 weighted image. Then MRI is able to detect bone marrow abnormalities, and if there is an abnormality in the bone marrow, then the fat will be disturbed. Like in this case, you got bone marrow edema with fluid instead of fat. Then you can evaluate the stages of bone marrow abnormalities in the spine by MRI, as I will mention after that. Finally, you should evaluate the spinal cord, and the cord is usually of intermediate signal in the T1 and intermediate signal in the T2 weighted image, just similar to the brain parenchyma. Then any abnormalities of the cord should be evaluated in the T2 weighted image, and also you should look for the coda equina nerve roots better in the axial image, more better than evaluation of the coda equina in the sagittal images. Finally, you should look for the paravertebral shadows for any abnormality. In most of the cases of degenerative diseases of the spine, you can see that the paravertebral shadows are normal. But in cases of trauma, for example, with fractures, you may say hemorrhage around the vertebra, and you should mention. In cases of inflammation, you can see an abscess in the paravertebral muscles. And in cases of neoplasms, you may see a tumor extension into the paravertebral muscles. Alhamdulillah Rabbil Alameen. Wassalamu alaikum wa rahmatullahi wa barakatuh.